So we are live, you can begin.
Can we start?
Yes, sir, you can start.
Hi everybody, welcome you all for the 9th Muscat International Ophthalmic Conference. We start our conference with a Symposium 1. I'm Dr. Muhammad speaking. I'm from organizing committee and moderator of this session. Symposium 1 will be about the multimodal imaging device by Ahmed Sarhan. He is a business unit manager of diagnostic equipment of Amico from the main branch of Dubai. Mr. Ahmed, please.
Hello, everyone. First, I would like to say that I'm honored to be with you today, and I'm really happy to have the opportunity to present our newest device that is being launched into market, which is Mevanti, the multimodal imaging device from Nidec. I will just share my screen now. It's clear?
Okay. Not clear.
Sorry, I'm trying to make it full screen. Okay, you can see my full screen, or it's fine, we can start?
So you can go on the slideshow option.
I am in the slideshow option. Can you, it's not apparent?
Can you click on end slideshow? Yeah, and at the top. Yeah, from beginning. Yes, can you click on display settings? It's at the top.
It's done.
Yeah, can you click on display settings and duplicate slideshow? Yeah, perfect.
Okay. So, as I mentioned, I'm really excited and happy to be able to provide, and to be able to have the opportunity to display the Mevanti to you today. The Mevanti is the newest multimodal imaging device that has been recently introduced by Nidec, and it is a combination between different imaging modalities that we will discuss now, along with a complete system of an OCT. So, we design with going through the design for the device. We will start with going through the design. The first part, our device is equipped with a motorized joystick, and it has a manual chain wrist, tilting head, and swinging head. Why is this important, having the tilting head and swinging head? Because as we will go through the imaging modalities, we will notice that we will be able to acquire different images with different sizes. And the tilting head and the swinging mechanism enables us to that we will be able to capture the full size of the retina, actually from OS rata to OS rata. The design of the device has a very compact design, as you can see. This is a laser control box, and this laser control box, it includes 4 different laser cavities, which we use to capture different imaging modalities. And of course, this is a table. This is our server and the PC isolation transformer, and this is a device in general. So Why are we calling this a multimodal imaging device? Because we have 4 different laser cavities with 4 different wavelengths that are incorporated in the device, and they are incorporated in this device so that we are able to capture different images for the retinas for different depths. And our system as well contains an OCT. So I will take you through now the imaging modalities. The device is able to take a dynamic FA, and when we are saying dynamic FA, it is a video capturing for the fluorescein angiography, dynamic ICG, which is also video capturing for ICG images, and we have the autofluorescent, and we have both options for autofluorescent, either by using the blue laser or the green laser, and we will discuss the difference between both. And we have the OCT and OCTA. The retro mode as well is available, and the colored images, and we can even break down the image into red, green, and blue, and infrared. And finally, we have the ultra-wide field imaging, which is applicable for the fluorescein and angiography, infrared, and colored mode, and ICG. We start with the colored images. Our system are using a combination for 3 different lasers to capture the colored image, as you can see. The size of this image is actually 89 degrees, and we use these 3 lasers simultaneously to provide us with the information for different depths inside the retina. So the blue laser provides us information regarding the sensory retina, the green laser provides us information from the sensory retina until the RPE, and the red laser provides information from the RPE till the choroid. And definitely all of the image can be taken through an undilated pupil. Minimum pupil diameter is 2 millimeters. These are examples for the colored images. And as you can see, what is unique in the Miranti, despite the fact that we are using the laser to acquire the image, but still we are maintaining the normal color for the fundus image. Plus the benefits, of course, of using the laser, which is that we are now able to penetrate more through opacity. So if you have any patient who is suffering from cataract or suffering from corneal opacity, still you will be able to capture very good images, as you can see in front of you. So, as I mentioned, this image is taken through 3 different lasers. So through the software, after capturing the image, you can even separate these images, and you can see the image that is captured by each individual lasers separately. So the first image, which is here, you can see this is taken by the blue laser, which is providing you information only about the sensory retina. This one provides information from sensory retina until RPE, and this is from the RPE until the choroid. So a single capture in a fraction of a second can provide you with multiple details regarding different segments or different layers within the retina. As for the autofluorescent, of course, you know that the autofluorescent, as an imaging technique, it targets only the RPE layer inside the retina. And what we are seeking to see is through this picture, we are seeking to see the function of the RPE, whether the RPE is functioning effectively. And in this case, we will see such a gray color. However, if it's hypoautofluorescence, we will see dark colors. Hypoautofluorescence, we will see a white color. And there are 2 main technologies in the market that are currently being used for the capturing of such an image. The first technology is using the blue laser. The second technology is using the green laser. For instance, if we look at Heidelberg are using the blue laser, and if we take a look on the Optus, they are using the green laser. Both technologies are nearly the same. However, there's a slight difference between them, because using the green laser provides us with better visualization for the area of the macula, because the green laser is minimally absorbed in the area of the macula, so it doesn't appear so dark. However, it is highly absorbed in the area of the optic disc. And the opposite is actually in the blue laser. The blue laser is highly absorbed in the area of the macula, so in a lot of cases it appears as a dark area, but it is minimally absorbed in the optic disc. When Nidec decided to introduce the Miranti, they decided that they want to provide you with full solution modalities. So they incorporated both options in the device, so that if you are having a patient coming with a picture taken from any device in the market and you want to make a follow-up for him, you will be able to capture a picture that by using the same technologies that he used. In the couple of slides, I will share with you a couple of pictures. As you can see, these are the pictures for the same patient, and it's being taken by the green and the blue. If we take a look, we'll be able to identify this is taken by the blue laser, and it is noticed through the apparent, the optic disc is more clear rather than compared to this picture, which is taken by the green laser. Sorry. Another example here, we can see here the pictures. If you can guess which one is green and which one is blue, definitely this one will be the green, because we can see that the macular area is more clear, and this one is taken by the blue lasers because the macular area is more dark, and the opposite is in the case of the optic disc. And definitely the angle of coverage for the image is the same like the colored image is exactly the same like the color. Moving ahead to another imaging modality, which is actually patent for NIDIC. And NIDIC introduced this imaging modality about a couple of years back when they introduced a device called F10. And now they reintroduce this imaging modality again with the Mevanti, and it's actually creating a lot of buzz in the medical community. And this imaging modality is called the retro mode. To be able to explain to you what is the retro mode, I will have to brief you what is the difference between the confocality and the retro mode. The confocality, it is like the, of course, you definitely all know, like the pinholes that you are using in the lenses or the rack of lenses, which is depending only to focus on the focus light that is coming from the retina. However, in the retro mode, we are avoiding the focus light. So we are shifting this hole to the right or to the left, or actually to the center. And our objective is to collect only the backscattered light. We don't want to have any laterally shifted. We don't have to have any focus light in our picture. And why is that? Because this will provide me with a 3D image for the morphological changes on the front surface of the cornea, as we will see, surface of the retina. So we have two different kinds. We have the retro mode dark field right, where the laterally shifted to the right, and we have the retro mode dark field left, where it is laterally shifted to the left, or we have the retro mode where we have a circular aperture in the middle, with the objective of all to provide me, as I mentioned, a 3D image for the morphological changes in the front surface or the sensory surface of the retina. So this is an example for the retro mode. As you can see very clearly the morphological changes on the surface of the retina, which is a new imaging modality, and I will share with you a couple of images in which you'll be able to detect certain pathologies in a much better way when you compare it to other imaging modalities that are now available in the market. And I have to say that the images of the retro mode is growing day after day. So if you take a look at this image, it is a colored image, and we can see some kind of an abnormality in here. However, when you can take a look in the retro image, it is clear that there is some kind of an edema that is apparent on the front surface of the retina. Another example, this is a blue autofluorescent image, and here you can see a hyper autofluorescent, where I can see there are 6 cells in the RPE. However, when I take here, I can see a more clear image for the morphological changes on the front surface of the retina using the retro mode. Another example here, I like this example, which is a colored image. And when you look at this image, you can say that the patient is nearly normal. However, as well, yes, some changes in the area of the macula. But when we take a retro image, we can see that there is massive druseness on the surface of the front surface of the retina. This is also another example, which is an autofluorescent image. And when we take a retro image for it, you can see the amount of druseness that is on the surface of the retina. So to conclude, what we can say is that the benefits of the retro mode, that it represents an additional tool that the doctor can use besides colored images and the autofluorescent images for him to be able to detect the pathologies in a better way. Moving ahead, I can move to the fluorescent angiography or ICG imaging. The fluorescent angiography or ICG imaging, of course, has been used for a very long time. The fluorescent angiography is used to visualize blood vessels on the retinal vasculars, and the ICG images is used to detect the blood vessels in the choroidal vessels or choroidal nodes. And despite that the OCTA has been introduced but yet the usage of the FA and the ICG imaging is still active all around the region, and it's highly requested by many doctors. I will share with you now an image, two videos, as you can see. To the right side, this is the ICG. To the left side, this is the FA. And this is for the same patient. Why I'm showing you this video to identify to you the benefits of having 3 different sensors which are incorporated in the Miranti device. Why is these 3 sensors important? Because it will enable you, in case you are injecting a mixed dye between fluorescein and ICG, that you will be able to record a video for the ICG and for the FA at the same time. Other competitors in the market have the capability of recording the videos, yes. However, they incorporate only one sensor. This means that they will either record the ICG or the FA. You cannot see both of them live at the same time, like what you can have with in the case of the Miranti. These are examples for our FA images, and these are examples for our ICG images. So, until now, we have spoke about 4 different images four different imaging modalities, about the colored imaging, about the autofluorescent, which you can capture by using the green laser or the blue laser, and also we spoke about fluorescent angiography images and ICG images. Now, moving ahead, we will speak about ultra-wide field imaging. Ultra-wide field imaging can be done with the Miranti just by adding a lens, and this lens is mounted just by a magnetic connection. It doesn't need anything, it doesn't need any professionality to mount it, it just attach it to the main imaging head. Magnetically, it will stick, and then you can capture an ultra-wide field image. The ultra-wide field images are compatible with infrared, colored images, red remote, fluorescent angiography, and the ICG. However, what is not compatible with the ultra-wide field is the OCT, OCTA, autofluorescent, and the ICG movies. So, through our ultra-wide field imaging, we can capture and at nearly about 163 degrees, just through also an undilated pupil. And this image also represents a colored image, and it is a combination between 3 different lasers that we mentioned earlier, which again, they are the blue, green, and red. This is another example for the ultra-wide field image, but as you can see, if we compare it to the first image, here you can see that the optic disc is in the middle, and here you can see that the optic disc is shifted. And this indicates that this image is taken through tilting the head. As I mentioned in the beginning of the presentation, we have a tilting and a swinging head, and the benefits of this is that you can go even further beyond the 163 degrees, where you can approach the ora serrata in different directions. So by acquiring maybe 4, maximum 5 images, you will be able to see nearly about 90 to 95% of the total retina. This is another example for the ultra-wide field, but in this case, this is for the FA. And as you can see, it is really beneficial to have an ultra-wide field image, especially in the FA, because you will be able to identify any pathological changes in the periphery, especially in the cases of like diabetic patients, in which you can see here that my hemorrhage are located a lot in the periphery. So in case you are taking a normal traditional 45 degree, for instance, in this case, you will be able just to see maybe this part, where any pathology in the periphery, you will not be able to detect. This is an ultra-wide field ICG image, and to the right and to the left, we have an FA image. So for you to be able to compare between both, the standard field of imaging is 89 degrees, while our ultra field image is 163 degrees, and you can capture, as I mentioned, the colored FA, ICG, or even the autofluorescent. So now we have spoken about nearly all the imaging modalities, and still, believe it or not, we didn't even cover half of the potentialities of this beautiful device, because we still have a fully capable OCT incorporated in this device. The technical specs of our OCT is that it can capture the images by 85,000 A scans per second. Definitely, it has the OCT, OCTA options, and it can take a B scan of 16.5 millimeters. And this is the widest B scan available now in the market. And even in the case of an OCTA imaging, it can take a 12 by 12 in a single capture, not through a panoramic creation. No, through a single capture, you can take a 12 by 12 and OCTA. The machine definitely is equipped by normative database, a Trojan eye tracker to track the movement of the eyes, and HD averaging, which is up to 120, where we can take the same specific B scans up to 120 times, which dramatically increases the quality of the image. And of course, also we have the anterior OCT module. I will start by giving you an example for the B scan, which is about 16.5 millimeters. As you can see, it is extremely wide. So here's the optic disc, and here's the macular area, and the image is really wide. You can see also, you can visualize vitreous very clear, and this is referring to 120 out of 120 of the HD averaging that I just mentioned. We have another feature that is not new in the Meranti, however, it was incorporated in all the OCTs introduced by Nidec, where you can choose the sensitivity of the device, which refers to actually the speed that you will be using. Because by default in any OCT, the higher the speed, the lower the quality, the lower the speed, the better the quality. So we provide you with 3 different modes in the device, which are referred to as fine, ultra-fine, and regular, which refers to different time speeds that you can use. If you choose the ultra-fine, like in the case of this image, you are using the minimum speed that you can use, which is 14,000 A scan per second, which enables you to get a higher resolution image. However, if you use the regular, which you will be using the 85,000 A scans per second, you will still get a good image, but it will be faster about 4 times when you compare it to the ultra-fine. So what I'm trying to say is we always give you options in the OCTs, that in Nidec OCTs, that where you can choose between the quality of the image and the time of acquisition, where you can choose depending on the cooperation of the patient in front of you. Another feature that is very unique in Nidec equipment is the Trojan eye tracker. We have a very unique eye tracker that tracks the movement of the patient's eye and takes a print for his retina through reference points. And this tracker even compensates the cycle torsion movement of the patient's eye. So this, which reflects the accuracy of such an eye tracker. And this is extremely important in the cases of follow-up, because once you make a single examination to the patient and you register it as a baseline, then once a patient comes back, the device will automatically go to the same exact position where you took the first examination, and he will take the second image based on the same parameters like you took the first image, and by which you will be able to compare head to head, and you'll be able to identify the progress of your patient. This is our macular map report. As you can see, we can provide the thickness map, color thickness map. We can display the images that are taken through the macular map. Also, you have the ETDRS chart, which is compared to normative database, and you have the ETDRS area, normative database map, and the deviation map. So for the follow-up analysis also, of course, to be clear, in this presentation, I'm not focusing mainly on the OCT, but I'm focusing mainly on the specific features that are new in the Meranti when we compare it to our RS3000 Advanced, which has been our OCT for the last couple of years, or even the 330. So for the follow-up analysis, you know that one of the important issues in the OCT is that, for instance, if you have a glaucoma patient, this is not a patient that will come once and go. He will come repeatedly, and you need to follow up, and we'll be able to identify his progress. So this is why we have placed a certain focus to the follow-up function in our OCTs. So in our follow-up, you can compare up to 5 examinations in the same screen. And the first examination will be providing the numerical results for the patient. And then the later examination will be the difference compared to the baseline. And also we have identified something that we refer to as a trend analysis, in which the system takes all the numerical values of all the included examinations and put it into a graph, so you'll be able to visualize the progress of the patient. And this is a very nice teaching tool in which you can use to demonstrate to your patients what is actually happening in their eyes. Also, we have an event analysis just for you to be able to identify the difference or the progress for the with the patient after doing a certain procedure. Yeah. So let's just put an example that you made an injection for one patient and you want to identify the difference in the thickness in his before the injection and after the injection. So just you press an event and you add the date of this event and you add the description, for instance, laser iodectomy or injection or whatever. And then the system will take this as a point of comparison in which he will be able to display to user progress of the patient before this event, and he will identify the event, and then he will show you the data or the numerical figures of the patient after the event. Also, this is a very nice educational tool in which you can explain to the patient and the progress of his case. Why does he need to take further injections, or why now he is good, he doesn't need to make further treatments. Another feature that we have is that we can correlate between the event analysis and any parameters that you would like, for instance, like the eyesight, like the IOP. So in this case, we put manually inside the system, we put the vision of the patient, and we can have it correlated with the progress of the patient's thickness for the retina, for him to identify also the patient to understand better his case. So these features that we have in our follow-up analysis are very nice features that are being used by most of our users to demonstrate and explain to their patients the progress in their case and the effectiveness of their treatments. So now, last part of our presentation, we will be speaking about the angioscan or the OCTA. The angioscan is a technology that has been introduced in the market since maybe about 5 or 6 years back, if I'm not mistaken. And it is a technology that maybe it's depends on the motion detection. So basically what is happening is that the system is capturing 2 consecutive images with nearly fractions of a second. That is the difference in the time between each of them. And the system is mapping or tracking only the moving parts in this image. So what is moving in an image of a retina is the blood. So by this technology, we are able to have a visualization to the blood vessels like the OCT, like the FA, through mapping the moving blood. However, what we need to understand regarding the OCT is that we can track only the moving parts. So for you to understand better, I will give you an example. So this is an image of a water tap. If I take this image and apply the same technology of the OCT in it, then what will appear in this image in my final report is only the water. This is because this is the only thing that is moving in this picture. Why is the understanding of this point is important? Because this will enable us to understand what we can detect via the OCTA and what cannot be detected. For instance, if we take a look at this is apparently, this is an FA image, and this highlighted part is a clear leakage. And this is an OCT image for the same patient for the same part. However, I cannot see the leakage. Why I cannot see the leakage? Because here the leakage is not dynamic, it is static. So it is not moving. This is why the OCT image cannot detect it. However, I can detect here the CMV, which is actually maybe the cause of this leakage. So what we are trying to say here is that the FA image cannot compensate the OCTA and the OCTA cannot compensate the FA. However, these are different tools that the doctor can use to complement the information that he has. So eventually he will be able to effectively diagnose the case. This is just an example for the cases. This is a normal OCT image, and this is an image for the retinal vena collagen, in which you can see here, this area is apparently hypoxic, where there is no blood vessels in it. And why it is dark? Because as it is hypoxic, there is no circulation and there is nothing movement, so there's nothing to be detected by the OCTA. Just also to be clear, this is a small comparison between the OCTA, FA, and ICG. Okay, FA and ICG, we can go to 150 degrees. The scan time takes maybe seconds to a few minutes. In the FA, it takes up to about 7 minutes. This is video still images only. Here we can take videos, and the display layer by layer in the OCTA. However, in the FA and the ICG, we cannot display layer by layer. Another important issue to understand when we are taking images for the OCTA is that always you have the option to either take this image by using an eye tracker on or by having the eye tracker off. And why is this important? Because this makes a significant difference in the time of the acquisition. So by using the eye tracker on, the time of the acquisition will be 4 times more compared to the closing the eye tracker. And the disadvantage of closing the eye tracker is that, as you can see in this image, it appears as if it is stitched, because actually what happens is any artifact will not be compensated because the eye tracker is off. Another example between the difference between eye tracker on and off, you can see it here. It's very visible, the stitching bit of the image. And even if you have an artifact like this, and this is simply a blink, but if you have an eye tracker on, so this will not happen because the system will go back to the same position in which the patient has blinked and will map it again. So in Mevanti, we provide you with both options where you can take an OCT image with the eye tracker on or the eye tracker off. And again, this is an option and the decision that has been taken by the practitioner or the doctor, in which depends on the patient in front of him, whether he is willing to stay a while to take an image, or you just want to capture whatever you want. This is our image. This is our screen for the OCTA, in which we provide you by standard. As standard, we provide you with 7 different layers analysis. Started with the superficial retina, outer retina, choroid capillaries, deep retina, outer retina, choroid capillaries, and the choroid and the vitreous. However, if you want to, you can press at any one of these maps and you can view it here in the main screen. And also you can dive here through the retina manually, and you can identify each and every layer separately. And each one of these layers, you can see the you can convert it into a visual density map or visual perfusion map, in which these maps will be converted into numerical figures, which is a very nice tool in case you want to make continuous follow-up for the patient. And recently also we have included the OCT follow-up option, so that you will be able to make a follow-up option for the OCTA images for your patients. And as I mentioned at the beginning of my presentation, is that the OCTA in the Mevanti is really unique, even when we compare it to the RS3000 Advanced, because now we can take a 12 by 12, which is a wide view for the OCT image, only through a single capsule and not through combining the images or stretching them through the panoramic image. So, finally, just before closing the presentation, I want to review with you what kind of OCTs now we have in NIDIC. So the main OCTs that we have been selling for the last couple of years is the RS3000, which has been updated last year, or maybe updated back in a year and a half. We introduced the RS3000 Advanced 2. This was top line in our portfolio, but not anymore after the introduction of the Mevanti. And we have also the Retina Scan View, which is a combination between an OCT and a fundus camera. It is an affordable OCT with affordable specs, affordable price, and it provides you with a versatility between between a fundus camera and the fluorescent and an OCT. And the newest member in our family is the Mevanti, which is a multimodal imaging device. It provides the best OCT, the maximum speed, the maximum accuracy, colored SLO, OCTA, green autofluorescent, blue autofluorescent, red remote, and ultra wide field, both also for fluorescent angiography and ICG. Thank you so much for your attention. I hope I managed to clarify to you the features that we have now in the Mevanti. And if any one of you have any questions, I will be more than happy to answer.
Well, thank you, Mr. Sarhan. It was an informative talk, really. Not sure whether anybody from attendee want to ask any question. So, since there is nobody there to ask, the common question usually asked, I will ask you regarding the OCT angle. Is it going to substitute the FFA? This is the common question usually asked in the future.
Yes. Yes, actually, this is a question that is being asked all the time. However, I have to say definitely no, because the OCTA is a beautiful feature. It is a very nice technology. It's an non-invasive technology which provides you with a clear visualization to the blood vessels. However, it has limitations, as I mentioned. And one of these main limitations is that you cannot see the leakages. So if a patient has a leakage and you do an OCTA, you will not be able to identify that such patient has a leakage. Leakages has to be identified through an FA, a traditional FA image.
Right. I don't have any more questions. Maybe Dr. Rashid. Okay.
دكتور أحمد محاضرة حقيقة قيمة وجميلة. طبعا OCT very important in our area more than maybe where it was made or produced because of type of retina disease in Oman and in GCC generally. So I think this is a great machine and very good. The only thing, this question always in my mind, as from I have history experience wise, maybe I'm from the first generation doctor here in the country in Oman, you can say. And my question always about the normal value. I have doubt always, is it the normal value, do you think, what's done in Western world or in Japan, suitable for our patient? We can say macular thickness, if they say 180 normal, this is not normal. If more than 200 microns, it is abnormal, maybe edema. Also same for the cornea. Do you think do we need to do a study to give those companies some normal value for our populations?
Well, actually, it would be great, doctor. It would be great to collect such normative database from our.
But it's always doubtful, and I asked many people in Western world. They said it will be great because those machines built on normal value, done on those kind. That's why they set the machine with normal value. So anything beyond the normal, consider abnormal.
Yes, true. So, what's unique about NIDIC is that we have different categories for normal values. So, for instance, we have North Americans, we have Hispanics, we have Caucasians, we have
That's
Asians.
why this.
So
the advantage
is to the Middle East. However, I have to agree with you totally in that this doesn't reflect 100% our people in the Middle East because the data has not been collected from the Middle East. So if
we're trying to do this in the future, we'll have.
And I'm sure that NIDIC would be very interested in doing so.
And we hope that maybe companies like your company, famous Amico, they can support such studies with machines maybe. And this will go back to the as very good because we consider always industry or as partners, not as commercial part.
Of course.
As partner together. So I think because in Western world, this is what happening in Japan, this cooperation between the industry and the physician end up with very good studies and results. And at the end, this data will go to the industry where they will improve or update their machine according to the findings.
Of course, doctor. We would be more than happy to cooperate with you in such a project. And the AFH and you specifically have been always a pioneer in introducing new technologies and projects in Oman. And definitely we can discuss it and we can plan it and we can proceed with such a project.
Thank you very much. Thank you. I don't know. The microphone to Dr. Muhammad Yarabi.
Thank you.
In the chat, there is one question from the audience. It says, what is the use of OCTA in glaucoma?
What is the A, sorry?
What is the use of OCTA in glaucoma?
Well, to be honest, the use of OCTA in glaucoma, glaucoma by the end of the day changes in the blood vessels in the retina, which we can identify through the OCTA. So again, the FA is effective. However, we have to inject fluorescein, and the fluorescein, by the end of the day, it is a dye which is toxic. So we cannot keep injecting the patient fluorescein every time he is coming to the clinic. So having the OCTA will complement the images that are being taken by an FA to provide you with more updated information about the structure of the blood vessels in the retina without having invasive injections in each and every visit. So I would like to emphasize again, this will not replace that. Both of them will complement each other. What I see in practices is that doctors maybe inject once a month or once every 45 days. And in regular visits, they can have OCT images without injection.
All right, thanks. Another question, we'll consider, I think, the last question, 1 more minute left. Does OCTA covers the peripheral retina?
Does OCTA cover what, sorry?
OCTA covers the peripheral retina. Is it a wide field? Right?
The maximum field for the OCTA is SLO field, which is 45 degrees. So the maximum that we can cover by the OCTA is the 12 by 12 millimeter. We cannot go beyond the 12 by 12 until now.
All right. Okay. Any other question? Doesn't look there's no more question. Thank you very much, Mr. Sarhan, for the good talk. It was really very informative. Thanks a lot.
It has been an honor. Thank you so much for your time. Thank you. Have a good day.
Thanks for that. Thanks.